You are sitting outside the examiner's hall at Gujarat University.
Oh, man, the tension.
Yeah, you know the feeling. The air conditioning is just a little too cold. Your palms are sweating, and you're just frantically reviewing this mountain of mental notes.
We have all been there.
Right, because you are an MD anesthesiology student, and you are staring down the absolute final hurdle of your postgraduate training, the Viva Voce, the oral exam.
Ultimate gauntlet.
Exactly. So today, in this deep dive, we are putting you in the hot seat. But we're giving you the cheat code. Our mission today is to completely dissect, analyze, and master one of the most high-stakes, physiologically chaotic, and, frankly, heavily tested cases in our entire specialty.
The Pheochromocytoma.
The anesthetic management of a pheochromocytoma.
Yes, it really is the holy grail of Viva topics, you know. If you can confidently manage a pheo in an oral exam, you're proving to the examiners that you possess this really profound interconnected understanding of autonomic pharmacology, cardiovascular pathophysiology, and real-time crisis management.
You're showing you aren't just a technician following a recipe.
Right. You're proving you are a consultant anesthesiologist.
So to guide you through this, I'm going to step into the role of your simulated fellow candidate. And joining me is your senior MD anesthesia faculty.
Hello. Ready to grill you.
Haha, exactly. And look, we are not going to just read you a textbook table of contents today. We're going to do a comprehensive, case-based exploration, entirely focused on the mechanisms, the whys and the hows that actually dictate our decisions in the operating room.
Because in the OR, a patient with a pheochromocytoma can swing from a hypertensive crisis that could, rupture a cerebral aneurysm straight into profound, intractable vasoplegic shock.
In like 30 seconds.
Literally 30 seconds. Examiners want to see that your reflexes are sharp and that your pharmacological arsenal is pre-calculated.
Okay, so let's establish our clinical picture, because the presentation is the bedrock of everything we're about to discuss.
Go for it. Lay out the case.
Right. So we are looking at a 20-year-old female presenting with headache, dizziness, and visual blurring. She has a known history of severe hypertension for 4 months.
At 20 years old. Red flag number 1.
Right, exactly. She is currently managed on oral Prazosin and Bilateral. Imaging confirms bilateral adrenal masses. We have a preoperative echocardiogram showing an ejection fraction of 60% with no regional wall motion abnormalities.
Okay, good.
And the planned surgical procedure is a laparoscopic bilateral adrenalectomy with consent for open conversion.
All right. So when the examiner looks at you across that table and says, present your case, you have roughly 15 seconds to take control of the narrative.
You can't just stumble through the vital signs.
Exactly. You do not just regurgitate the heart rate and blood pressure. You have to synthesize the data into a risk profile. Your opening summary needs to be crisp, targeted.
What's the perfect script for that?
You say, I present a 20-year-old female, a diagnosed case of bilateral pheochromocytoma, currently optimized on alpha and beta blockade, with preserved left ventricular function, posted for laparoscopic or open bilateral adrenalectomy. My primary anesthetic goals are to manage massive intraoperative hemodynamic fluctuations, blunt hypertensive crises during tumor handling, aggressively treat profound vasoplegia following tumor ligation, and provide mandatory perioperative steroid cover.
Wow. Okay, that is dense.
Yeah.
I want to isolate a specific phrase you used in there, though. Preserved left ventricular function.
Yes, very important.
Because in a 20-year-old patient, I think most junior residents would just assume the heart is structurally sound, right? But by leading with the EF of 60%, you are actively anticipating an examiner's trap.
You are.
I imagine we're specifically ruling out catecholamine-induced cardiomyopathy here.
You hit the nail on the head. You are preemptively striking the examiner's follow-up question. Chronic, massive catecholamine excess, like the constant bombardment of the myocardium with endogenous adrenaline and noradrenaline, it doesn't just cause ischemic strain.
It's toxic, right?
It causes a direct toxic cardiomyopathy. We are talking about intracellular calcium overload leading to contraction band necrosis and myofibrillar degeneration.
Jeez.
Yeah. The heart essentially beats itself to death at a cellular level. It leads to a dilated, globally hypokinetic left ventricle. So by stating her EF is 60% right up front, you are signaling to the board, I understand the long-term pathophysiological damage this tumor inflicts, and I have verified her myocardium can handle the stress we are about to induce.
That sets the stage perfectly. It just immediately proves foundational knowledge. And to truly understand how this tumor dictates our anesthetic plan, I think we need to look at the cellular machinery driving it. Let's dissect the pathophysiology.
Absolutely essential. Exam gold right here.
Right. We know it's a catecholamine-secreting tumor of chromaffin tissue, which is derived from the embryonic neural crest. And while we are dealing with bilateral adrenal masses today, we should always keep the rule of tens in mind.
Oh, yes. A classic.
10% being extra-adrenal paragangliomas, 10% malignant, 10% bilateral, and 10% familial.
Right. And the embryological origin is crucial because it actually dictates the biochemical output. The chromaffin cells in the adrenal medulla are essentially modified postganglionic sympathetic neurons.
Okay.
They synthesize catecholamines starting from the amino acid tyrosine. So tyrosine is hydroxylated to L-DOAA,
Right.
which is then decarboxylated to dopamine, which is then hydroxylated to norepinephrine. Now here's where the anatomy really matters. In a normal adrenal medulla, an enzyme called phenylethanolamine and methyltransferase, or PNMT, converts norepinephrine into epinephrine.
And if I remember correctly, PNMT expression is highly dependent on high concentrations of local cortisol, right?
Okay.
Which it receives because the adrenal medulla is physically bathed in the venous effluent of the adrenal cortex.
Precisely. This is exactly why extra-adrenal paragangliomas, which lack this proximity to the cortisol-producing cortex, typically only secrete norepinephrine.
Oh, that makes so much sense. But our patient has bilateral adrenal masses, so she is likely secreting massive, unregulated tidal waves of both norepinephrine and epinephrine into her systemic circulation.
Right, entirely bypassing the body's normal negative feedback loops.
So let's map these circulating catecholamines to the clinical effects we actually see. The severe hypertension and intense peripheral vasoconstriction. That is a direct result of massive alpha-1 receptor agonism.
Yes. The alpha-1 receptors on the vascular smooth muscle are GQ coupled.
Right. They activate phospholipase C, increase intracellular IP3 and calcium, and just clamp the vessels down tight.
Like a vice. Meanwhile, the epinephrine is hitting the beta-1 receptors in the heart.
Those are G's coupled, right?
Exactly. G's coupled, increasing KMP, leading to profound tachycardia and increased inotropy. But the most insidious systemic effect, and honestly the one that causes the most anesthetic nightmares, isn't the high pressure itself.
It's the volume status.
Volume depletion is the silent killer in these cases. It really is. Because the alpha-1 receptors are commanding such chronic, intense vasoconstriction, the entire systemic vascular container shrinks.
I always think of it like pinching a garden hose incredibly tight for months.
That's a great analogy. The systemic vascular resistance is incredibly high. And in response to this artificially high pressure, the kidneys invoke pressure natriuresis. They excrete sodium and water, attempting to lower the blood pressure.
Because the kidneys think, oh, pressure's too high, let's dump fluid.
Exactly. So the result is a patient who is severely, chronically hypovolemic, but you don't see it because the vascular bed is clamped down so tightly around that diminished volume.
It's terrifying. And compounding this hypovolemia is the state of the adrenergic receptors themselves. We often talk about receptor downregulation in these patients.
Yes. Very heavily tested concept.
I kind of think of it a bit like alarm fatigue in the ICU. Like if the ventilator alarm rings continuously for a week, the nursing staff eventually just stops hearing it. In the Pheochromocytoma patient, the alpha and beta receptors are subjected to a continuous deafening alarm of catecholamines.
Alarm fatigue is a brilliant way to conceptualize the pharmacodynamics at play here. At a cellular level, continuous exposure to high levels of agonists causes the G-protein-coupled receptors to become phosphorylated by G-protein-coupled receptor kinases.
Okay.
This allows a protein called arrestin to bind to the receptor, which literally physically internalizes the receptor into the cell.
Wow, it just pulls it right off the surface membrane.
Removes it completely. The receptors that remain on the surface are desensitized, so you physically have fewer receptors available, and the ones that are present require massive amounts of catecholamines just to maintain normal resting vascular tone.
Which means we are walking a terrifying physiological tightrope. We have a shrunken vascular tank, practically no circulating blood volume, and a receptor pool that is both exhausted and completely reliant on a toxic tumor just to keep the lights on.
That is the exact physiological nightmare you are dealing with.
This brings us to the preoperative preparation. In my mind, if you haven't perfectly optimized this patient in the pre-op clinic, you've already lost the patient on the table.
Oh, without a doubt.
The most sacrosanct rule we have is alpha blockade before beta blockade.
It is an absolute non-negotiable axiom of anesthesia. Alpha before beta.
Okay.
Always. You initiate therapy with an alpha antagonist. Our patient is on Prazosin, which is a selective competitive alpha-1 blocker.
Right.
Historically, though, and still in many centers, Phenoxybenzamine is used.
Let's dig into the pharmacology there, because examiners love asking about the choice of alpha blocker. I would think a competitive antagonist like Prazosin is safer because its effects wear off, preventing, prolonged postoperative vasoplegia. Why do many experienced clinicians still swear by Phenoxybenzamine despite its terrible side effect profile?
It all comes down to the mechanism of binding. Phenoxybenzamine is a non-competitive, irreversible alpha-1 and alpha-2 antagonist.
Irreversible.
Yes. It covalently binds to the receptor. It alkylates it. Once it binds, that receptor is functionally dead. The body literally has to synthesize brand new receptors to restore function, which takes 24 to 48 hours.
Okay, but why is that desirable?
Because when the surgeon dissects the tumor in the OR and releases a tidal wave of norepinephrine, that surge cannot overcome the phenoxybenzamine blockade. The receptors are permanently capped.
Okay.
If you use a competitive blocker like Prazosin, a massive intraoperative catecholamine surge can simply outcompete the Prazosin for the receptor sites, leading to a breakthrough hypertensive crisis.
That makes perfect sense. The non-competitive nature is basically an impenetrable shield. But returning to the golden rule alpha before beta, let's role-play a Viva scenario for the listener.
Let's do it.
The examiner looks at you and says, "Doctor, your patient is sitting in the clinic. Her blood pressure is 200/110, and her heart rate is 140 beats per minute. She complains of severe palpitations. Why can't I just give her a low dose of propranolol to bring her heart rate down and make her comfortable before starting the alpha blocker?"
That is a classic trap, a lethal one.
So what's the answer?
If you administer a non-selective beta blocker or even a beta-1 selective blocker at high enough doses, you are blocking the beta-2 receptors in the peripheral skeletal muscle vasculature.
Right, and beta-2 receptors mediate vasodilation.
Exactly. They are the body's only remaining physiological pressure release valve against the tumor's output. Meanwhile, the tumor continues to pump out massive amounts of norepinephrine, which now acts entirely unopposed on the alpha-1 receptors.
Because the beta-2 vasodilation is gone. So you get unopposed alpha vasoconstriction.
Exactly. The systemic vascular resistance, which is already dangerously high, shoots into the stratosphere. The heart is suddenly pumping against a colossal afterload. And because you just blocked the beta-1 receptors, you've removed the heart's compensatory inotropy.
Wow.
You've created a scenario of infinite resistance and blunted contractility. The left ventricle simply fails. You induce acute, massive congestive heart failure and acute pulmonary edema right there in the clinic.
A lethal mistake. Okay, so we establish alpha blockade first, and as those alpha receptors are blocked, that intense vasoconstriction finally releases. The vascular container expands to its normal physiological size, and this is where the hidden hypovolemia we discussed earlier is unmasked.
Yes. The tank suddenly gets much larger, but the volume of fluid inside it is exactly the same. The venous return to the heart plummets.
This is why the second pillar of preoperative optimization is volume expansion.
Right. It feels deeply counterintuitive to prescribe a high-salt diet and aggressive intravenous fluid therapy to a patient who presents with severe hypertension, but it is physiologically mandatory.
If you don't fill up that newly expanded vascular bed, what happens?
The patient will suffer profound orthostatic hypertension. They will literally syncopize just walking to the bathroom.
In our case, the patient is also on labetalol. Now, labetalol is an interesting choice because it's a combined alpha and beta blocker.
It is.
But its ratio of alpha to beta blockade is about 1:3 orally and 1:7 intravenously. The beta blockade is much stronger. So we rely on the Prazosin to do the heavy alpha lifting first, and the labetalol acts primarily to control the tachycardia once the alpha shield is in place.
Perfectly stated.
So how do we objectively prove to the examiner that this optimization phase is complete? We can't just guess that the tank is full and the receptors are blocked.
No, you quote the Roizen criteria.
Ah, yes.
Dr. Michael Roizen established these specific objective endpoints, and reciting them is pretty much a rite of passage in the Viva.
Walk us through them.
There are 4 criteria. First, the patient's blood pressure must be consistently less than 130/80 millimeters of mercury while seated for 24 hours prior to surgery.
Okay, a 130/80 seated.
Second, there must be no severe orthostatic hypotension. Specifically, the standing systolic blood pressure must remain above 90 millimeters of mercury. This proves your volume expansion is adequate.
Right, standard systolic greater than 90.
Third, the resting heart rate should be between 60 and 70 beats per minute when seated and shouldn't exceed 80 upon standing.
Got it.
And fourth, the ECG must be pristine. No ST or T wave changes indicative of ongoing ischemia, and there should be no more than one premature ventricular contraction in a 5-minute continuous monitoring strip.
If she fails even one of those Roizen criteria, we cancel and delay the case. It's that simple.
Absolutely.
Now, regarding preoperative investigations, the examiner will expect us to justify every test we order. We know we need 24-hour urine for vanillin mandelic acid, or VMA, and plasma-free metanephrines.
Right.
And metanephrines are actually much more sensitive, correct, because catecholamine release from the tumor can be episodic, but the intratumoral metabolism via COMT catecholamical transferase is continuous, providing a steady leak of metanephrines into the blood.
That is an excellent high-level pharmacological point. You are absolutely correct. Now, for imaging, beyond the standard CT or MRI to localize the gland, an MIBG scintigraphy scan is vital.
MIG, so that's medeodobenzoguanidine.
Exactly. It is a norMBFN analog. It gets taken up by adrenergic tissue, allowing us to scan the entire body to rule out those extra-adrenal paragangliomas or distant metastatic disease.
Because you do not want to remove the bilateral adrenals, only to have the patient crash from a hidden retroperitoneal mass.
That would be a disaster.
And from a strictly anesthetic perspective, we mandate the ECG and echocardiogram to rule out the cardiomyopathy like we discussed. We must also rigorously check the electrolyte panel and the fasting blood glucose.
Oh, the glucose is critical.
I want to emphasize the glucose here. We usually associate sympathetic nervous system surges with the fight-or-flight response, which mobilizes energy. In a pheochromocytoma, the massive alpha-2 receptor stimulation on the pancreatic beta cells strongly inhibits insulin secretion. Simultaneously, beta-2 stimulation promotes hepatic glycogenolysis.
Exactly. These patients exist in a chemically induced secondary diabetic state. They are profoundly hyperglycemic and insulin resistant. Establishing a baseline glucose is critical because, as we will discuss later, the moment that tumor is removed, the metabolic pendulum swings violently in the opposite direction.
All right, so our 20-year-old patient has met the Roizen criteria. She is optimized, her intravascular volume is restored, her receptors are shielded, she arrives in the pre-op holding area.
The calm before the storm.
Let's pivot to Part D, the anesthetic plan and monitoring. This is where the practical execution begins. What goes on this patient before we even think about touching a syringe of propofol?
Well, standard ASA monitors go on immediately. A 5-lead ECG specifically monitoring leads 2 and V5 for ischemia detection, a reliable pulse oximeter, capnography, and a core temperature probe. However, the most critical decision you make in this phase is the timing of your invasive monitoring.
The arterial line.
Yes. The arterial line must be inserted before the induction of anesthesia while the patient is awake, utilizing local anesthesia.
Now let me push back on that, just playing devil's advocate for the exam. Arterial line insertion can be quite painful, and pain causes anxiety.
True.
Anxiety stimulates the endogenous release of catecholamines, which is exactly what we're trying to avoid. Wouldn't it be more humane and, frankly, physiologically safer to perform a smooth intravenous induction, secure the airway, and then place the radial arterial line while she is deeply anesthetized and oblivious?
It is a really tempting thought, but it is a fatal error in this patient population.
Why is that?
The transition from an awake state to a state of general anesthesia, specifically the manipulation of the airway during direct laryngoscopy and intubation, provokes one of the most violent sympathetic reflex arcs in all of clinical medicine.
Oh, right, the intubation response.
Even in a perfectly optimized pheochromocytoma patient, the mechanical stimulation of the supraglottic nociceptors can trigger a massive, instantaneous catecholamine surge. A standard, non-invasive blood pressure cuff takes anywhere from 30 to 60 seconds to cycle and display a reading.
And a lot can happen in 60 seconds.
In 60 seconds, an unmonitored systolic blood pressure can spike from 120 to 280, resulting in a devastating intracranial hemorrhage. You absolutely must have continuous, beat-to-beat, real-time hemodynamic data streaming on your monitor before you push your induction agents.
So if the waveform shoots up, you need to see it the microsecond it happens.
Exactly, so you can push your rapid-acting vasodilators immediately.
The A-line is our early warning radar. There is no compromise. We use the radial artery typically, and we should pay close attention to the arterial waveform itself. In a severely vasoconstricted state, we might see a high dicrotic notch, and during our intraoperative vasodilator therapy, We will see that notch slide down the descending limb as systemic vascular resistance drops.
Very good point.
Beyond the A-line, we also need central venous access.
Yes, a central venous line, ideally a multi-lumen catheter in the internal jugular or subclavian vein, is highly recommended. It serves two purposes. First, it allows us to monitor central venous pressure trends, which is crucial for managing the massive fluid shifts and assessing preload in a patient with a dynamically changing vascular capacity.
Right. And the second purpose.
Second, and practically more important, you will be running an orchestra of incompatible, highly concentrated vasoactive infusions, nitroprusside, esmolol, noradrenaline, vasopressin. You need dedicated, secure central lumens for these.
You can't be pushing those through a peripheral IV.
Definitely not.
No.
Additionally, a Foley catheter is mandatory before surgery begins. Hourly urine output is the most reliable, continuous indicator of splanchnic and end organ perfusion.
Now, if the EF was poor, say 35%, we might even consider a pulmonary artery catheter or transesophageal echocardiography, right?
Yes, TE is phenomenal for giving us real-time visualization of left ventricular end diastolic area, showing us exactly how empty or full the heart is, regardless of the confusing pressure readings.
But given our patient has a healthy EF of 60%, a CVP trend and arterial line are generally sufficient.
Correct.
Let's move into the operating room. We are at Part E, induction of anesthesia. This is an absolute minefield, and examiners love to march you through it drug by drug.
The overriding philosophy for induction here is the creation of a profound pharmacological shield. We want zero sympathetic breakthrough. No pain, no anxiety, no coughing, no reflex tachycardia. It must be a deep, immaculately smooth transition.
Let's build the recipe. We start in the holding area with midazolam. Anxiety triggers the locus coeruleus and the sympathetic nervous system, so midazolam provides anxiolysis and amnesia.
Right.
As we move to the OR, we need an opioid to blunt the sympathetic response to the laryngoscope. And a standard 1 to 2 micrograms per kilogram of fentanyl simply isn't going to cut it here, is it?
Not even close. You are trying to block the MR.
Remind us what that is.
The minimum alveolar concentration required to blunt the autonomic response to noxious stimuli. For intubation in a pheochromocytoma, we use high-dose opioid techniques. You might use 5 to 8 micrograms per kilogram of fentanyl, or better yet, a target-controlled infusion of remifentanil.
Remifentanil is brilliant here because its context-sensitive half-time is roughly 3 to 4 minutes, regardless of infusion duration.
Exactly. You can dial it up to massive doses to completely obliterate the intubation reflex and then rapidly dial it down once the tube is secure without causing prolonged postoperative respiratory depression.
That's a great clinical pearl. For the hypnotic agent, propofol or etomidate are our mainstays because they offer predictable cardiovascular stability.
Etomidate is particularly useful if the patient has underlying cardiomyopathy, though we have rolled that out in our specific case.
And about 2 minutes prior to inserting the laryngoscope blade, we administer intravenous lignocaine at 1.5 milligrams per kilogram.
The lignocaine is crucial. It acts directly on the voltage-gated sodium channels in the peripheral nerves, specifically blunting the afferent sensory traffic from the tracheal mucosa. It dampens the reflex arc before it even reaches the central nervous system.
Finally, we need profound neuromuscular blockade. We want to avoid any coughing or bucking on the tube.
Right, because that would drastically increase intra-abdominal pressure and literally squeeze the tumor.
Rocuronium or vecuronium are drugs of choice here.
Yes. They are aminosteroid non-depolarizing agents that are entirely hemodynamically stable. They do not release histamine, and they do not have vagolytic properties.
Now that we have the recipe for success, let's discuss the blacklist. In the Viva, mentioning the wrong drug will instantly terminate your exam.
Oh yeah, they will walk you right out.
Let's go through the agents we must absolutely avoid, and more importantly, exactly why we avoid them. Number 1, ketamine.
Ketamine is a phencyclidine derivative that acts as an NMDA receptor antagonist, but crucially, it inhibits the reuptake of catecholamines at the presynaptic sympathetic nerve terminal.
Oh, wow. So it leaves more norepinephrine in the synapse.
Exactly. It also directly stimulates the central sympathetic nervous system. In a patient whose physiology is already saturated with toxic levels of norepinephrine, ketamine will act as a match in a powder peg, triggering a catastrophic hypertensive crisis.
Avoid at all costs. Number 2 on the blacklist, dysflurane.
Dysflurane is incredibly pungent. Rapid increases in its inspired concentration severely irritate the airway receptors. This irritation triggers a reflex sympathetic discharge, leading to sudden, severe tachycardia and hypertension. We cannot risk that sympathetic surge.
Number 3, pancuronium.
Pancuronium is a long-acting muscle relaxant that possesses inherent vagolytic properties.
Meaning it blocks the vagus nerve's slowing effect on the heart.
Right. It blocks the muscarinic receptors at the sinoatrial node, leading to unopposed sympathetic tone and significant tachycardia. In a pheochromocytoma patient, controlling the heart rate is already a massive challenge. We do not want to artificially elevate it.
And finally, the histamine releasers. Drugs like thiopentone, morphine, and atracurium.
Histamine is a direct, potent secretagogue for chromaffin cells.
It triggers them to release more hormones.
Exactly. If you administer a drug that causes mast cell degranulation and systemic histamine release, that histamine binds to H1 receptors on the adrenal tumor, triggering massive intracellular calcium influx and explosive exocytosis of the catecholamine-containing vesicles. It is essentially a pharmacological squeeze of the tumor. Avoid them at all costs.
Okay, so the patient is asleep. We've given our high-dose remifentanil, our propofol, our rocuronium, and our lignocaine. The patient is deeply anesthetized and fully paralyzed. You are holding the laryngoscope. But before you open the mouth, what is happening on your IV pole?
This is the hallmark of a safe, consultant-level anesthesiologist. You anticipate the crisis before it happens. Before I perform laryngoscopy, my rapid-acting vasodilators, typically sodium nitroprusside or nitroglycerin, are not just drawn up in a syringe.
They need to be ready to go.
They are connected to the central line carrier fluid, the line is flushed to the hub, and the pump is proglazed. My hand is literally hovering over the start button. If I visualize the vocal cords and I see the arterial line waveform shoot upward, I do not ask the nurse to find the drug. I start the infusion instantly. You must treat the spike within seconds.
We navigate the intubation successfully. The tube is secured, the vitals are stable, the surgeon hasn't scrubbed in yet. Let's discuss Part F maintenance of anesthesia. We are relying on volatile inhalational agents, specifically sevoflurane or isoflurane.
Yes, sevoflurane is generally preferred. It is smooth, non-pungent, and provides a dose-dependent decrease in systemic vascular resistance.
Which is highly beneficial in antagonizing the tumor's vasoconstrictive effects.
Right. It depresses myocardial contractility slightly, but usually within acceptable limits.
We pair the volatile agent with continuous infusions. We keep that remifentanil or fentanyl infusion running to maintain a high analgesic floor, ensuring that surgical stimulation never breaks through to the autonomic nervous system. And we must maintain a continuous infusion of our muscle relaxant. We cannot rely on intermittent boluses here.
Absolutely not. Complete, uninterrupted neuromuscular blockade is mandatory. If the block begins to wear off and the patient regains diaphragmatic tone, or worse, if they cough against the ventilator, the intra-abdominal pressure will spike violently.
And that mechanical pressure is transmitted directly to the retroperitoneum.
Compressing the adrenal gland and wringing the catecholamines out of it like water from a sponge, paralysis must be absolute until the tumor is out.
This brings us to the core of the surgical procedure and Part G, intraoperative management. The surgical dissection begins. The surgeon mobilizes the liver or the spleen, entering the retroperitoneal space. They locate the adrenal gland. And the moment they physically touch and manipulate that tumor, all hell breaks loose.
This is the hypertensive crisis. Direct mechanical handling of the tumor mass forces concentrated, unregulated boluses of norepinephrine and epinephrine directly into the adrenal venous drainage.
Straight into the inferior vena cava.
And into the systemic circulation. Your patient's blood pressure can go from a stable 120/80 to an astronomical 260/40 in a matter of heartbeats.
The alarm is blaring, the surgeon is working. What is our primary weapon to drop that afterload?
Our drug of choice is sodium nitroprusside, or SNP. It is an ultra-short-acting, potent arterial and venous vasodilator. You run it as a continuous infusion, typically starting at 0.5 to 2 micrograms per kilogram per minute, titrating up to a maximum of 10.
Let's delve into the mechanism of SNP because it dictates why it's so incredibly effective. SNP interacts with oxyhemoglobin, dissociating to form nitric oxide.
Yes.
The nitric oxide diffuses into the vascular smooth muscle cells, activating soluble guanylate cyclase. This converts GTP to cyclic GMP, which in turn decreases intracellular calcium concentrations, leading to profound, immediate smooth muscle relaxation.
It works in seconds.
And its half-life is around 2 minutes, giving us incredible minute-to-minute titratability.
That is the exact depth of knowledge required for the Viva. However, you must also be prepared to discuss its toxicity.
Right, cyanide.
Yes. Prolonged use or high doses of SNP can lead to cyanide toxicity, as it contains 5 cyanide moieties per molecule. You monitor for this by looking for a rising mixed venous oxygen saturation because the tissues cannot extract oxygen, and a worsening metabolic acidosis.
Okay, but what if the hypertensive spike is accompanied by ischemic changes on our ECG? Because that huge afterload is increasing myocardial oxygen demand, while the high-end diastolic pressure is decreasing subendocardial perfusion.
Good question. If you see ST segment depression on leads 2 or V5, you pivot to nitroglycerin, or NTG. While SNP is an arterial and venodilator, NTG is primarily a venodilator at lower doses, reducing preload and myocardial wall tension.
It takes the strain off the heart.
More importantly, it directly dilates the epicardial coronary arteries, restoring oxygen supply to the struggling myocardium.
We also have phentolamine in our arsenal. It's a direct, short-acting, competitive alpha-1 and alpha-2 antagonist. We can give it in 2 to 5 milligram intravenous boluses for rapid control. But I really want to talk about a drug that has become incredibly prominent in recent literature and is an absolute favorite for modern examiners.
Magnesium sulfate.
Yes, MgSO4.
Magnesium is a phenomenal, elegant adjunct in pheochromocytoma management. It acts as a physiological calcium channel blocker.
How does it work at the cellular level?
At the level of the adrenal medulla, it competes with calcium at the voltage-gated calcium channels on the presynaptic chromaffin cell membrane. By blocking calcium influx, it actively inhibits the vesicular exocytosis of the catecholamines themselves.
So it stops the release at the source. It doesn't just treat the symptom.
Exactly. It's a prophylactic shield. And systemically, it acts as a direct vasodilator and an antiarrhythmic, giving a loading dose of 30 to 60 milligrams per kilogram, followed by an infusion, drastically reduces the requirement for the more volatile drugs like SNP. It stabilizes the entire physiological landscape.
Speaking of arrhythmias, the massive circulating catecholamines severely lower the threshold for myocardial irritability. If the patient develops ventricular tachycardia or frequent multifocal PVCs, your first line is intravenous lidocaine or amiodarone.
Right. And if they develop a severe supraventricular tachycardia driving the heart rate to 160 or 180, you use esmolol.
But only after alpha blockade.
Exactly. Esmolol is an ultra-short-acting beta-1 selective antagonist rapidly metabolized by red blood cell esterases. Its half-life is 9 minutes. But you only push esmolol for rate control after you have verified that your vasodilators are running at a high rate and the alpha receptors are fully antagonized.
If you give esmolol during a hypertensive crisis without adequate alpha block,
You return to the unopposed alpha scenario and risk acute heart failure, just like we talked about in the pre-op clinic.
Okay, let's talk about the surgical factors. We mentioned the planned surgery is a laparoscopic adrenalectomy. The patient will likely be in a lateral decubitus position. This isn't just about padding pressure points, is it?
No, positioning is a hemodynamic event. Moving an anesthetized, alpha-blocked, potentially volume-contracted patient into the lateral decubitus position with the kidney bridge elevated causes massive fluid shifts.
Blood pools in the dependent limbs.
The viscera shift, potentially compressing the inferior vena cava, drastically reducing preload. And worse, the physical rolling of the patient can mechanically compress the tumor, initiating a crisis before the surgeon even makes an incision. Movement must be agonizingly slow, coordinated, and monitored beat by beat.
And then comes the laparoscopy itself. The surgeon inserts the varus needle, or the trocar, and insufflates the abdomen with carbon dioxide gas to create a pneumoperitoneum. This introduces a cascade of physiological insults.
It creates a perfect storm. First, the physical insufflation raises intra-abdominal pressure, often up to 15 millimeters of mercury. This pressure physically squishes the adrenal gland, releasing hormones.
Second insult.
Second, this increased pressure compresses the intra-abdominal arterial capacitance vessels, mechanically increasing systemic vascular resistance and worsening the hypertension. Third, it compresses the inferior vena cava, further decreasing venous return to the right heart.
And finally, the CO2 gas is highly soluble. It absorbs across the peritoneum into the blood, leading to hypercarbia.
And hypercarbia directly stimulates the central sympathetic nervous system, causing further endogenous catecholamine release.
So to counter this, we must proactively hyperventilate the patient, right? Increasing our tidal volume or respiratory rate to blow off the excess CO2 and maintain strict normocarbia.
Yes. We must also coordinate with the surgeon to insufflate slowly, in stages, allowing the cardiovascular system to adapt while we hold our vasodilators ready.
It requires intense vigilance and constant communication across the blood-brain barrier, the ether screen, between the anesthetist and the surgeon.
The communication is just as important as the pharmacology.
Which brings us to the climax of the entire procedure, Part H, The surgeon has meticulously dissected the retroperitoneal tissue. They have isolated the main adrenal vein, they place a titanium clip across it, and they cut it. The tumor is officially completely isolated from the systemic circulation.
This is the cliff edge drop. If the dissection was the fire, this is the ice. Examiners will drill you heavily on the physiology of this specific moment.
I can visualize it clearly. You have your SNP infusion running at 4 micrograms per kilo per minute to fight a blood pressure of 220/120. Your heart is pounding. Then the surgeon calls out, vein is clipped, and within 60 seconds the blood pressure plummets to 60/40.
The arterial waveform just flattens.
The monitors sound a completely different, terrifying alarm. It is profound, sudden cardiovascular collapse. Why is it so severe?
There are 4 overlapping physiological reasons for this devastating post-ligation vasoplegia. 1, the immediate absolute withdrawal of endogenous catecholamines.
Because the half-life of norepinephrine is barely 2 minutes?
Right. The body has been relying on this massive toxic output to maintain vascular tone, and suddenly the tap is shut off.
2, the lingering pharmacokinetics of your anesthetic drugs. If the patient was optimized on phenoxybenzamine, remember, it's a covalent, irreversible bond. Those alpha receptors are permanently dead, and they will remain dead for another 24 hours.
Furthermore, the SNP or phentolamine you infused 3 minutes ago to fight the dissection surge is still circulating, actively dilating the vessels.
Right, you have to turn that off. 3, receptor downregulation. As we discussed with our alarm fatigue analogy, the alpha receptors that aren't blocked by phenoxybenzamine have been internalized into the cell.
They are downregulated. They are physically unavailable to respond to normal physiological baseline levels of sympathetic tone.
And 4, the unmasking of the volume deficit. Even if you optimize them perfectly preoperatively, the surgical fluid losses, combined with the sudden massive increase in the size of the vascular container when all vasoconstriction ceases, means the patient is relatively severely hypovolemic.
The tank is massive and the fluid volume is inadequate.
So your pressure hits 60/40. What is your immediate algorithm?
Step 1, turn off every single vasodilator infusion instantly.
Duh.
Step 2, communicate with the surgeon. If they are still insufflating, ask them to release the pneumoperitoneum temporarily to restore inferior vena cava flow and preload.
Okay. Step 3.
Step 3, aggressive massive fluid resuscitation. You open the IV crystalloids wide. You push colloids. If there is blood loss, you transfuse. You must rapidly fill the newly expanded vascular space.
We guide this fluid resuscitation using our CVP trends, or better yet, our TE, looking at the left ventricular and diastolic area. But we know that fluid alone is rarely enough to rescue a pressure of 60/40 in a chemically denervated patient. We need vasopressors.
Yes.
But here is the critical examiner trap. If I give standard doses of ephedrine, which relies on endogenous catecholamine release, or even standard doses of phenylephrine, a direct alpha-1 agonist, what happens?
Nothing happens. The blood pressure will not budge. Ephedrine fails because the nerve terminals are depleted. Phenylephrine fails because the alpha-1 receptors are either covalently bonded by phenoxybenzamine or internalized via downregulation. They are deaf to the drug.
So what do we reach for to save this patient?
You need incredibly potent direct-acting agents. You initiate an infusion of noradrenaline, often at surprisingly high doses, simply to overwhelm the remaining blockade through sheer receptor saturation. But the true secret weapon, the answer that will secure your distinction in the Viva, is vasopressin.
Let's explain the pharmacology of why vasopressin is the ultimate rescue drug here.
Vasopressin completely bypasses the broken, exhausted adrenergic system. It does not interact with alpha or beta receptors.
Where does it bind?
It binds to specific V1 receptors located on the vascular smooth muscle. These V1 receptors are GQ-coupled, leading to phospholipase C activation, IP3 generation, and calcium release from the sarcoplasmic reticulum, causing intense, direct vasoconstriction.
And because they haven't been bombarded by the tumor, they still work.
Exactly. Because the V1 receptors have not been bombarded by the tumor, they are fresh, upregulated, and highly responsive. Vasopressin will restore systemic vascular resistance when every other catecholamine fails.
That is a beautiful application of receptor physiology. Vasopressin circumvents the blockade. Okay, we push the vasopressin, we load the volume, the pressure stabilizes at 110/70. The surgeon finishes the operation, closes the fascia, and we extubate the patient smoothly.
But the danger is far from over.
We transition to part 1, postoperative management.
The operation isn't over when the drapes come down. These patients require mandatory admission to the intensive care unit for at least 24 to 48 hours. The invasive arterial line must remain in situ.
Because their hemodynamics will continue to fluctuate wildly, right?
Yes. They might swing back into hypertension as the peripheral tissues slowly release stored, sequestered catecholamines back into the blood, or they might suffer recurrent hypotensive crashes as the vasopressin wears off and the phenoxybenzamine hangover persists.
Now, I want to bring up a complication that often gets completely overshadowed by the dramatic blood pressure swings. We've spent an hour talking about hypertension and vasoplegia, but in the ICU, one of the most lethal threats to this patient's brain isn't vascular, it's metabolic.
Ah.
Why are we absolutely terrified of postoperative hypoglycemia?
This is a sophisticated physiological concept that examiners love. Remember the preoperative metabolic state we discussed?
Right, the secondary diabetic state.
The tumor's massive output of alpha-2 agonists was constantly suppressing the pancreatic beta cells, inhibiting insulin release, while simultaneously driving hepatic glycogenolysis. The body was accustomed to a low-insulin, high-glucose environment.
The pancreas was functionally clamped shut.
Exactly. The moment the surgeon clips that adrenal vein, the alpha-2 suppression vanishes instantly. The pancreatic beta cells, which have been suppressed for months, suddenly wake up and overcompensate.
They just dump insulin.
They release a massive, unregulated rebound surge of insulin into the bloodstream. We call this rebound hyperinsulinemia. Concurrently, the catecholamine-driven glucose production in the liver abruptly halts.
So you have a tidal wave of endogenous insulin hitting a system with no new glucose production. The glucose drops from 200 to 30 in a matter of hours.
And the patient, who is likely sedated or recovering from anesthesia, cannot exhibit the normal sympathetic signs of hypoglycemia like sweating or tachycardia because their sympathetic system is totally blunted.
They will quietly slip into a profound, irreversible hypoglycemic coma.
Yes. Brain damage occurs rapidly. Therefore, strict hourly blood glucose monitoring via arterial blood gas or finger stick is absolutely mandatory for the first 24 to 48 hours in the ICU. You must anticipate this drop and proactively treat it with continuous dextrose infusions, typically 5% or 10% dextrose, tailored to their hourly readings.
Let's discuss postoperative pain control. It is a laparoscopic surgery, but significant visceral pain remains. Pain causes secondary sympathetic surges, which we want to avoid. Usually, for major abdominal surgery, we would advocate strongly for a thoracic epidural.
We would.
But in a post-Pheochromocytoma patient, an epidural is akin to a loaded weapon.
You must use extreme caution, and many consultants consider it relatively contraindicated in the immediate post-ligation phase.
Why is that?
A thoracic epidural provides excellent analgesia by blocking the afferent sensory nerves. However, it concurrently guarantees a dense preganglionic sympathectomy. It completely blocks the sympathetic efferent nerves traveling to the splanchnic vascular bed, causing massive, unbridled vasodilation.
Because a thoracic epidural will guarantee a dense sympathectomy, your post-ligation hypotensive crash will be completely unresuscitatable. You are adding a massive regional pharmacological vasodilation on top of an already profoundly vasoplegic, volume-depleted system.
Exactly. You remove the very last shred of autonomic vascular tone the patient has left. The cardiovascular collapse can be fatal.
So what do we do instead?
Instead, we rely heavily on systemic multimodal analgesia, intravenous paracetamol, and ASAIDs if renal function permits, and carefully titrated opioid PCAs, patient-controlled analgesia. Ideally, using fentanyl rather than morphine to avoid any residual histamine release. Regional fascial plane blocks, like a transversus abdominis plane or TAP block, which do not cause sympathectomy, are excellent, safe alternatives.
We are entering the final phases of our case, Part J, special considerations. We must return to the specifics of our 20-year-old patient. She didn't just have a pheochromocytoma removed, she had a bilateral adrenalectomy. Both of her adrenal glands are now in a pathology specimen bucket.
This specific detail completely alters the postoperative survival paradigm.
How so?
The adrenal glands are composed of the medulla, which produces the catecholamines, and the cortex, which is vital for life. The cortex produces mineralocorticoids, primarily aldosterone, which regulates sodium and water retention, and glucocorticoids, primarily cortisol.
By removing both glands, we're inducing absolute 100% iatrogenic adrenal insufficiency. If we fail to recognize and treat this immediately, the patient will plunge into an Addisonian crisis.
An Addisonian crisis is a catastrophic state of refractory cardiovascular collapse. Cortisol is not just a stress hormone. It is physiologically permissive for vascular tone.
It's permissive for vascular tone, meaning
Cortisol is required to upregulate alpha-1 receptors on the vascular smooth muscle and to maintain normal endothelial integrity. Without circulating cortisol, the vascular smooth muscle becomes entirely unresponsive to endogenous or exogenous catecholamines.
So even if you are pumping in maximum doses of noradrenaline and vasopressin,
The blood vessels will remain dilated and the patient will die from intractable shock.
this is an absolute pass or fail point in the Viva. If the examiner gives you a bilateral adrenalectomy case and you forget the steroid cover, you will fail the station. What is the precise pharmacological protocol we must initiate?
It is a non-negotiable mandate. Intravenous hydrocortisone must be administered. Typically, we give 100 milligrams of IV hydrocortisone intraoperatively, timed just before the surgeon ligates the vein of the second adrenal gland.
To get ahead of it.
This provides immediate non-genomic membrane stabilization and begins the genomic upregulation of receptors.
And postoperatively in the ICU.
The coverage must be continuous. We initiate a hydrocortisone infusion, typically 200 milligrams over 24 hours, or 50 milligrams intravenously every 6 hours. This continuous high-dose coverage mimics the body's maximal stress response.
And eventually, they just transition to oral meds.
Over the subsequent days and weeks, as the patient stabilizes, the endocrinology team will slowly taper this intravenous dose down to a daily oral maintenance dose of hydrocortisone and fludrocortisone, which the patient will require for the rest of her life.
We've covered immense physiological ground. Let's synthesize this in Part K, exam integration. The Viva is a performance. You need to structure your knowledge logically and rapidly. Let's role-play the ultimate crisis management algorithm.
Let's do it.
You are in the hot seat. The examiner leans forward and says, "Doctor, the surgeon aggressively retracts the adrenal gland. The arterial line shows a blood pressure of 280 over 150. The heart rate is a 135. The ET segments are depressing. Walk me through your exact stepwise actions."
Step 1. Call for help. State clearly, I will declare a hypertensive crisis and call for an additional anesthetist.
Step 2.
Step 2. Eliminate the trigger. I communicate firmly with the surgeon. Stop all surgical manipulation immediately.
Step 3.
Step 3. Deepen the anesthetic depth. I increase the dial on my sevoflurane vaporizer and administer a bolus of propofol to ensure zero sympathetic breakthrough from awareness.
Step 4.
Step 4. Protect the end organs. I increase the inspired oxygen fraction, the FiO2, to 100% to maximize myocardial oxygen delivery.
And Step 5.
Step 5. Pharmacological intervention. I instantly start my pre-connected sodium nitroprusside infusion, titrating rapidly to effect, and consider adding nitroglycerin given the ST segment depression.
And Step 6.
Step 6. Once, and only once, I have verified that the blood pressure is responding to the vasodilators and the alpha effect is blunted, I administer a 10 milligram bolus of esmolol to control the tachycardia and reduce myocardial work.
That is a flawless, structured response. Notice how the pharmacological intervention was Step 5. Examiners look for the basic safety steps, calling for help, stopping the stimulus, 100% oxygen before you reach for the exotic drugs. Let's review the classic Viva traps we've discussed today. Trap number 1. Why alpha before beta?
To prevent unopposed alpha-1 mediated extreme vasoconstriction against a beta-blocked failing left ventricle, which would lead to acute congestive heart failure.
Trap number 2. Why the profound hypotension immediately following tumor ligation?
A combination of sudden catecholamine withdrawal, residual non-competitive alpha blockade from phenoxybenzamine, downregulated and internalized alpha receptors, and an unmasking of chronic hypovolemia upon vasodilation.
Trap number 3. What is your primary pressor of choice for refractory post-ligation vasoplegia?
Vasopressin, because it acts on V1 receptors, completely bypassing the desensitized and pharmacologically blocked adrenergic receptor system.
Now, in most Viva stations, there is a whiteboard in the room. The examiners love a candidate who can draw. It proves you aren't just reciting memorized lists. It proves you understand the architecture of the disease. What 2 diagrams should our candidate be prepared to sketch out rapidly?
First, draw the catecholamine synthesis pathway. Tyrosine, converted by tyrosine hydroxylase to L-DOPA. L-DOPA converted by dopa decarboxylase to dopamine. Dopamine converted by dopamine beta hydroxylase to norepinephrine. And finally, norepinephrine converted by PNMT to epinephrine. Circle the PNMT step and verbally note that it requires cortisol from the adrenal cortex.
And the second diagram?
Second, draw a hemodynamic timeline graph. Put time on the x-axis and mean arterial pressure on the y-axis. Plot the patient's baseline. Draw a small spike at intubation, indicating you anticipated it. Draw massive, jagged peaks during the surgical dissection phase, labeling them tumor manipulation. And then draw a precipitous vertical drop labeled vein ligation. Visually mapping the crisis proves you possess the complete clinical picture.
Excellent. As we wrap up this deep dive, let's distill the core philosophy of this entire case. Managing a pheochromocytoma isn't about memorizing a textbook. It's about respecting the physiology. It's about understanding that you are managing a patient whose entire cardiovascular system has been fundamentally altered by months of toxic hormonal exposure.
It all comes down to understanding receptor exhaustion, the unmasking of hidden volume deficits, and strictly adhering to the golden rules of pharmacological sequence.
You establish the alpha shield first.
You fill the expanded tank. You induce anesthesia with profound depth to prevent the reflex arcs. You aggressively dilate during the surge, and you employ alternative receptor pathways like vasopressin during the crash.
And you never, ever forget the metabolic consequences, the rebound hypoglycemia and the Addisonian crisis in bilateral cases.
And never forget the steroids.
To the student at Gujarat University listening to this, you have the knowledge. You understand the why behind every drug on your cart. You understand the how behind every hemodynamic swing on your monitor. When you walk into that exam hall, you don't need to be afraid of the pheochromocytoma case. You take control of the narrative, you preempt the examiner's traps, and you demonstrate the calm, calculated expertise of a senior clinician. We have meticulously mapped out the perfect standardized plan for a diagnosed, optimized pheochromocytoma.
It is the ultimate exercise in controlled anticipation.
But I want to leave you with a final provocative thought to mull over tonight as you close your textbooks. We had the luxury of a preoperative diagnosis today. We had Prazosin, we had Roizen criteria, we had an awake arterial line.
A luxury we don't always get.
Exactly. What happens when a patient with an undiagnosed pheochromocytoma, perhaps an extra-adrenal paraganglioma sitting silently near the bladder, comes into your OR for a completely unrelated routine surgery, say a simple laparoscopic appendectomy?
A terrifying scenario.
You don't have alpha blockers on board. You haven't optimized their volume. You don't have an A line in place, just a blood pressure cuff set to cycle every 5 minutes. And suddenly, upon intubation or abdominal insufflation, their heart rate hits 160, and the pulse oximeter plethysmograph completely flattens out from massive vasoconstriction.
You don't know it's a pheo, you just know the patient is dying.
How sharp are your diagnostic instincts and your crisis management reflexes going to be when the physiological bomb goes off without a warning timer?
Surviving that relies entirely on the foundational physiological principles we discussed today.
Think about it. Master the physiology and you master the specialty. Good luck in your exams, Gujarat. You are going to be brilliant. We will catch you on the next deep dive.